I'm Jana Broughton with Superior Health Quality Alliance. I am a QIA, and I'm joined today with three of my peers. We have Patty Leonard, Jessica Henkel, and Amy Magner, and we are all going to be presenting a little bit today, each of us taking a section as we talk about F881 antibiotic stewardship, which is the second in our F-Parts F-TAG series. So to kick us off, before we get started, just as a follow-up for those of you that were on last week, I'm going to drop into, or should be dropped into chat shortly, the discussion that we had around, or the question that we had on enhanced barrier precaution, cleaning of resident rooms. And it was a great question. You guys are always like asking the best questions. And we took it to a couple different experts out there in the field, and we got a couple different answers. But the reality is, Patty, if you want to share what your answer was, what did you receive from your answer for the question about cleaning of EBP rooms?
Sure, I stuck it into chat, but I apologize. The links didn't come up. I could not find any clear direction. And the question was, should enhanced barrier precaution rooms be cleaned last, along with isolation rooms? The FAQs on enhanced barrier precautions does talk about some cleaning things. I think that was question number 27. One of the sources that I contacted recommended that if the resident is colonized, that those rooms should be done last. But that is then going to require some education with your EBS staff. They also suggested a risk assessment and, developing a facility policy and procedure. So I would say take that back to your team and talk about what the risk to your organism, to your organization is, and, what you're comfortable doing. And you can always reach out to the IPRAT team or back to us, and we can, sit down and talk to you one-on-one about that as well. So, but great question.
Yeah, each of the state health departments do have a group. Michigan, it's called IPRAT, and I forget the names. I know Wisconsin has a group. We met with them in Minnesota, and a group of nurses that come out and will work with you directly on one-on-one with infection control. And they're a good source of information specific to your state also. So excellent questions. All right, so let's get us kicked off. So the objectives for today are to identify the Centers for Medicare and Medicaid Services, CMS requirements for antibiotic stewardship for skilled nursing facilities, and then to understand and implement an antibiotic stewardship program in your facility, how to employ evidence-based criteria for antibiotic use and surveillance, and then how to implement tools to evaluate the effectiveness of your antibiotic stewardship program. So with that, I'm going to turn it over to Jessica.
Thanks. So we're going to begin with a brief introduction to antibiotic stewardship. And we have a quick poll to kick us off. I'm starting to see answers come in. It looks like.
So which of the following have been identified consequences of the overuse of ABT in long-term care facilities, Jessica?
So we have the answer E, all of the above. It does come with increased risk of adverse drug events, C. diff, and MDROs, and an increase in drug and food interactions. So I would say 88% of everybody got that correct. So wonderful job. All right, we can move to the next slide. So back in 1928, Alexander Fleming made the wonderful discovery of antibiotics, which changed the course of medicine, altered bacteria so it would be destroyed or that it could not grow, and saved countless lives. It's also used in prevention of infections in many different patient populations, but it has come with some unintended consequences. Perfect. So most of the unintended consequences of antibiotic overuse or antibiotics has come from antibiotic overuse. So on average, 4.1 million people enter a nursing home every year. And 1 in 10 of those nursing home residents is on an antibiotic at any given time. Overall, 70% of nursing home residents will receive a course of antibiotics every single year, but up to 75% of those antibiotic courses have been deemed inappropriate and or unnecessary. So this has led to increased adverse drug events and anaphylactic reactions, increased risk of getting Clostridioides difficile infections, while taking antibiotics and up to 12 weeks after the end of the antibiotic course. And in our older adults, this is particularly dangerous because 90% of deaths associated with C. diff infections occur in individuals greater than 65. And 1 in 9 of our older adults with a C. diff infection die within 30 days of that diagnosis. So it is a significant cause of morbidity and mortality in our long-term care residents. And it's also led to the colonization and development of MDROs, which has led us then down the road of enhanced barrier precautions. Next slide. So one of the things that we can do as healthcare providers is invest our time into antimicrobial stewardship. And you can look at many professional organizations and it can be defined in a number of ways, but it basically boils down to using antibiotics when they're needed in an appropriate way for the appropriate organism for the appropriate time, and not using them when it's not necessary. I like the last definition, treat them as a precious non-renewable source, because that's kind of where we're at. So what does this mean for us in long-term care? So if we go to the state operations manual, our regulations tell us that as a part of our infection prevention and control program, we have to have an antibiotic stewardship program that includes antibiotic use protocols and a system to monitor their use. The intent of this regulation is to make sure that we're developing and implementing protocols that optimize the treatment of infections, making sure that residents who require an antibiotic get that appropriate antibiotic. But we're also reducing the risk of adverse events, including development of MDROs and unnecessary or inappropriate antibiotic medication use. And we want to develop, promote, and implement a facility-wide system to monitor the use of antibiotics. The CDC has summarized the core elements that are required for antibiotic stewardship in nursing homes. So we're going to go through them in a little more detail in the next few slides. So we need to have leadership, accountability, and expertise involved in our program. We have to have the development of protocols and a system to monitor. And Amy and Patty are going to go into this a little more in depth further into our presentation, but we really need leadership, support, and accountability. We need our medical director on board. We need the consulting pharmacist. We need nursing and administrative leadership involvement, and the IP needs to be heavily involved in the antimicrobial stewardship program. The program protocols are going to describe how the program will be implemented and how antibiotic use will be monitored. So this again is part of your overall infection prevention and control program. It does need reviewed annually, not just your policies and practices, but your overall outcomes. You need to have a system reporting for your antibiotic use. You can get that information from your pharmacy, from your EMR. If you're still one person that likes to use paper and pencil, you can keep track of it on your own, but you need some system every month that you're tracking and trending your antibiotic use. You're looking at antibiotic resistance, and later on, Amy will talk to us about an antibiogram. And we're going to need to look at outcome measures related to antibiotic use. Are you having MDROs? Are you having adverse events? Things like that. So when you're monitoring antibiotic use, you also need to provide that feedback to prescribers. So one of the top things you're going to look at is, how is the resident responding to the antibiotic? Are they getting better? Are they having any adverse events? That antibiotic timeout is a really important time to make sure you've got your labs and your cultures back. Are you using a susceptible antibiotic for the organism that you're treating? Has your pharmacy reviewed, and do you need extra labs? Do you need dose reductions for kidney function? Are you looking at those things? And has the process gone in compliance with facility protocols? And when facility protocols aren't followed, make sure that there is a follow-up action. So you're educating, you're looking at process breakdowns and discussing that with your frontline staff. As a part of your infection assessment process, you really need standardized tools to assess. And Patty will talk to us in a little bit about the Loeb's criteria for assessing for an antibiotic need, assessing for that active infection. Using the S-bar is kind of the nurse's tool to communicate with that provider to say what's going on, what's the background. I mean, does the resident have a history of asymptomatic bacteremia that maybe they don't need an antibiotic for? Do you need to maybe recommend to watchfully wait for the resident to see how the condition is going to change? You increase vitals, increase assessments, increase fluids. Those are your tools that you can use to talk with your providers prior to getting that antibiotic order. Maybe you need to look at labs a little bit thoroughly to see if there's something else going on. But if it does boil down to coming to needing an antibiotic, then make sure those orders are complete. They include the indication, dose, and duration of treatment. And the last part of the core elements is the education requirements. So at least annually, make sure you're educating prescribers and nursing staff, including your CNAs, on antibiotic stewardship and the protocols for your facility. Discuss with them your MDROs, which they're probably a lot more aware of now with enhanced barrier precautions. Make sure you're also including resident and family education during admission, displaying commitment letters, sharing pamphlets. You can talk about these things in resident and family councils. Make sure that they're aware of your commitment to antibiotic stewardship and how you're going to work as a team to make sure that residents get antibiotics when it's appropriate, but avoiding them when it's not. And we have listed their CDC Train site that you can use to train your staff and providers on antibiotic stewardship. So along with antibiotic stewardship, we could also receive tags for unnecessary medications, for failure to have a drug regimen review. So it's nice to make sure that you're always doing that drug regimen review at the start of an antibiotic. You could have a citation for infection prevention plan or for your infection preventionist role. The resident right to be informed in advance about care and treatment, making sure they're understanding the need for the antibiotic or the need to maybe not proceed with one at the time. You could have tags for quality of life, quality of care. You could get one for care planning if you're not care planning infections properly. And you could also get a tag for infection control training or lack thereof for staff and providers. So here are some tools that you can use from resources that are experts in infection prevention and control. We have the Agency for Healthcare Research and Quality. They have a toolkit. We have a program from the Minnesota Department of Health. The CDC has wonderful training. And we also have listed a resource that we have from Superior Health. You're also welcome to contact the Superior Health, one of us as quality improvement advisors, and we can give you and your facility individualized support for your facility's antimicrobial stewardship program. So Amy's going to walk us through antibiotic stewardship policies and procedures.
Thanks, Jess. So I'm going to talk a little bit about policies, procedures in regards to antibiotic stewardship as well as compliance, and then provide you some information on antibiograms. So with the antibiotic stewardship policies and procedures, so as part of your facility's antimicrobial stewardship program, you need to include antibiotic stewardship policies and procedures that are designed to guide providers in the appropriate use of antibiotics within your facility. Next slide, please. So we have a quiz here. So if you could answer the question, so which of the following best describes the infection preventionist role in antibiotic usage monitoring?
It looks like overwhelmingly 100%
Yes.
is saying number one.
Fantastic. That is correct. So with the antibiotic stewardship policy, the purpose of the policy should include policies that are updated to reflect your facility's current standards of practice. And your policy should be reviewed annually, as Jess stated. We find that a lot of facilities do not review those policies, those antibiotic usage policies, and it's really important that you are doing so, as well as updating them as needed or as regulations change. You also want to make sure that your policies limits antibiotic resistance, improves treatment efficiency and outcomes for your residents, promotes resident safety, especially by avoiding toxicity, reduces treatment efficiency, improves treatment efficiency and outcomes, reduce treatment-related costs. And so having policies that are put into place, and make sure when you're updating your policies, reviewing those, it can be very costly for a facility, especially if you're misusing antibiotics. Obviously, you're aware of that. So again, this can actually reduce treatment costs. And then some of those procedures that you want to implement could possibly be the 5 Ds of antimicrobial therapy. And so the right Ds would be the right drug, the correct dose, the right drug route, suitable duration, and then timely de-escalation. And so when you hear timely de-escalation, you want to think about the pathogen-directed therapy. So meaning selecting the most appropriate treatment against the identified pathogen. So often you may have to switch to a more narrow spectrum antibiotic to target the causative pathogen that you're treating, that's based on an identified culture. Additional procedures would include implementing an antibiotic stewardship program, and then adhering to clinical and surveillance criteria. Some procedures that could also help support and strengthen your facility's antibiotic stewardship program include, Jess had mentioned, a timeout. So this could be a 48 to 72 hour timeout. And so when you hear a timeout, that could actually become part of a core practice of your antimicrobial stewardship program. So a timeout is an active reassessment of an antimicrobial prescription. So you take 48 to 72 hours after the first administration of medication, and then you do a reassessment. So you're allowing medical staff to take into account the laboratory cultures, sensitivity testing results, and then the patient's response or the resident's response to therapy and current condition. A timeout is also strategy to promote, to reevaluate your antibiotic appropriateness. So if you don't include the timeout, I really do encourage you to do so. And they have some great resources available to you that you could actually, you don't even have to create your own. They are easy accessible. And then additional procedures that you could implement is the 4 moments of antibiotic decision-making. So when you think about those 4 moments, the first one would be ask yourself, does your resident have an infection that actually requires an antibiotic? So actually, before initiating your antibiotic, you want to ask yourself, is it important to pause and review all relevant clinical and laboratory data that actually would weigh your decision to start an antibiotic or not? So basically, you're comparing the benefits versus the harm of your resident if you initiate that therapy. Your moment 2 could be asking, did the provider order the appropriate antibiotic based on cultures before starting the antibiotic, and what therapy should be initiated? Moment 3 is a day. Just kind of pause after you have initiated the antibiotic. Go back and reassess your patient. Ask yourself, can you stop that antibiotic? And that should be a question you should be asking yourself every time an antibiotic is started. Does the resident need to continue on that antibiotic, or can you actually stop that? And then the 4th moment would be, what duration of antibiotic therapy is actually needed for your resident's diagnosis? So specific recommendations can be found throughout, especially the AHRQ safety program toolkit. And it's really important that you're also documenting the plan duration and that you include the stop date in that resident's medical record. And some additional procedures that you can consider in your antibiotic stewardship program would be implementing an antibiotic algorithm, identifying antibiotic stewardship champions, which I'll address in just a little bit, regular auditing, prescribing, self-evaluating prescribing practices. So are you actually doing the self-evaluation of your providers who are actually prescribing antibiotics? You can initiate infection modules such as a urinary tract infection model, and then integrating quality improvement initiatives. Next slide, please. So a successful antibiotic stewardship program should include accountability. You as an IP will want to identify individuals who will be responsible for leading your antibiotic stewardship implementation program in your facility. In addition to your role as an IP, there are additional disciplines that you need to include. So we'll start with your medical director. So your medical director should be the one setting standards for your antibiotic prescribing practices for all healthcare providers in your facility and individuals who are licensed to prescribe antibiotics. Your medical director should also be overseeing adherence to antibiotic prescribing practices, reviewing antibiotic use of data, and then ensuring that you are actually adhering to those best practices, meaning the right drug, the right dose, the right amount, and the right time. In addition to individuals responsible for your program, You also could include or should include your director of nursing. So your director of nursing should be establishing those standards for nursing staff to assess, monitor, and communicate changes in a resident's condition that could impact the need for antibiotics, as well as using their influence as a nurse leader to help ensure antibiotics are prescribed only when appropriate, and then educating frontline nursing staff about the importance of antibiotic stewardship and explaining the policies in place to improve antibiotic usage. You also can include and should include your consulting pharmacist. And so your pharmacist is a key team player and stakeholder in your program. You want to make sure that your pharmacist is providing education to your staff about the different types of antibiotics and their uses. They should be reviewing your antibiotic prescriptions as part of the drug regimen review for new medications and ensure they are ordering appropriately. They need to establish laboratory testing protocols to monitor for adverse events and drug interactions related to use of antibiotics in your facility, especially high-risk medications. And then they should be reviewing microbiology culture results and providing feedback to your prescribers on initial antibiotic selection, and letting your staff know that they're using the right drug and you're treating the right infection with the right medication. In addition to who is involved with your antibiotic stewardship program, as an IP, it's important that you understand that education is the key. So education is key for infection prevention, antibiotic stewardship implementation, and early sepsis. So frontline nursing staff are critical for the success of a facility's antibiotic stewardship program. As the IP, you should be providing antibiotic stewardship education during new hire orientation as well as annually. That's essential. And we find that a lot of times that frontline staff, your nursing staff, they're not receiving any education upon hire about facilities antibiotic stewardship programs. So it's important that you just make sure they're educated in your program and your policies. Your education should include explaining appropriate antibiotic usage combined with a positive treatment recommendations followed by a negative one. Educate clinical staff about your facility's antibiotic stewardship program. Be sure to include which clinical and surveillance criteria your facility actually follows. Keep in mind that McGear's and Loeb's are the primary criteria that we use, but don't assume that your staff have a clear understanding of what McGear's and Loeb's actually is. So as part of your antibiotic stewardship education, make sure you're including McGear's and Loeb's or whatever criteria you're actually using. Some facilities use one or the other, and some facilities actually use both. You also can provide education, as I spoke, the 72-hour timeout. As I stated, this is an effective approach, especially with an antibiotic when it's prescribed, especially it's from an outside source. Meaning if it's antibiotic that's been prescribed from the emergency department and there's the resident sent back to your facility, a lot of times, your residents prescribed an antibiotic, they're sent back to your facility and there's no follow-up. So that 72-hour window would actually give you time to assess your resident to make sure that the medication that they were prescribed is actually the correct medication they should be taking. And then what we have found during an ICAR assessment with a lot of our homes as quality improvement advisors, one of the questions that we will ask on the ICAR is if the facility actually provides education to nursing staff on hire and in the past 12 months. And as I've stated, the majority of facilities will often tell us, no, they don't. So just something that you want to think about. And then finally, providing ongoing education to residents and families. It's so important that we're providing education to residents and their families. This helps to set expectations and address concerns about antibiotic prescribing in your facility. You will want to start these conversations early, especially if it's a resident who is a new admission to your facility and if they've been taking antibiotics for a long time. So if you have a resident who has a long history of antibiotic use, you're going to want to have those conversations early because they won't understand if you discontinue their medication because a lot of times they become dependent on those. And that may raise concerns for both the resident and family. So again, have those conversations as early as possible. Next slide, please. And then as part of your facility's antibiotic stewardship program and your policies and procedures in your facility, it does require that your provider prescribe an antibiotic documents in your resident's medical record or during order entry the indication of cause for the antibiotic treatment. So you want to make sure that if they're prescribed, your resident's being prescribed an antibiotic, that order has an indication why that medication is actually being prescribed. And then make sure you're adhering to that documentation, your facility's documentation policy. You also want to develop and provide a specific treatment recommendations based on national guidance and local susceptibility to assist with antibiotic decision-making for common clinical conditions. Your antibiotic reviews, your facility should have and adhere to a formal procedure for performing a follow-up assessment, especially 2 to 3 days after a new antibiotic start. That's that 48 to 72-hour timeout. And then a core element to improve your antibiotic use is by taking action through policy and practice change. Nursing homes that are implementing prescribing policies and changes to improve antibiotic use, the introduction of new policies and procedures which address antibiotic usage should be done in a stepwise fashion. So if you make any changes to your policies, make sure you're communicating that information to your staff. Antibiotic review, assessing treatment after antibiotic start, we talked about that, and then tracking and reporting is so essential. As an IP, that will be one of your many responsibilities, is that you are actually tracking and reporting all antibiotic usage within your facility and reporting that to medical providers as well as to your QAPI. Next slide, please. Now for this next few slides, we're going to talk about compliance. And to understand antibiotic stewardship compliance, it is important to understand what compliance actually means. So often compliance is often used interchangeably with competency, and they are actually two different, they're not the same. So compliance is actually the act of following or adhering to guidelines, policies, and procedures that have been set forth as regulatory or at corporate level. So you want to make sure that you're monitoring your compliance of usage of antibiotic use in your facility. Next slide, please. And so your facility's antibiotic stewardship compliance can be achieved by reviewing your facility's antibiotic outcome measures. This can be done by monitoring your trends and outcomes through surveillance, and often that will be the responsibility of the infection preventionist. Compliance is also validated by tracking your facility's usage of antibiotics, and then tracking your uses also helps guide practice changes. So not only are you tracking how much and what antibiotics are actually being used, but it does help guide changes in your facility, as well as what appropriate antibiotics could be possibly used for specific microorganisms. And then tracking your data can be obtained from your primary laboratory. So if you have a farm or a laboratory that you contract with, if you just reach out to that laboratory, they can actually provide you with cultures, microorganisms over a period of time if you're looking to track specific outbreaks or the use of antibiotics for a specific microorganism in your facility. Your laboratory can provide you with that information, as well as your contracted pharmacies. You also can obtain compliance through generated reports that you can obtain through your electronic health records. And you can also, which is very time consuming, you can do manual chart reviews. Compliance can also be monitored by using an antimicrobial stewardship program team. So if you have a antimicrobial stewardship team, that's fantastic. But if you don't, as an IP, you may want to think about creating one. And so this team can actually lead and advocate for careful and correct use of antibiotic usage in your facility. I do encourage you, though, that if you do create or if you're in the process of creating an antimicrobial stewardship team, that you do include multidisciplinary team members. So you want to make sure you maybe have a pharmacist, physician, nurses, and other healthcare professionals who can actually utilize their skill sets to improve antimicrobial medications and how they're being used in your buildings. And then antimicrobial stewardship champions. If you don't have champions are a great asset to teams. They are your change agents. So you could actually use your champions to monitor your compliance. So again, if you don't have champions, this is just an idea that you could actually implement as a infection preventionist, to have individuals that you delegate to monitor compliance in your facility. And you can actually make that part of their job description. And then finally, monitoring compliance can be achieved through monthly, quarterly QAPI reporting. As an IP, ask yourself, are you having meaningful conversations with your QAPI about your facility's antibiotic stewardship program and your antibiotic usage? You want to make sure that you are presenting the trends that you identify with your antibiotic usage, and that you're actually initiating those conversations. If the intent of your QAPI is to be a framework to achieve your system-wide improvement in your facility, it's important that you're having, again, those meaningful conversations with your team members. Next slide, please. Some key elements of compliance in the use of antibiotics in your facility should also include implementing antibiotic usage protocols and procedures according to current regulations. You want to monitor the use of antibiotics within your facility, and then ensure the appropriate antibiotics are being prescribed. Next slide, please. And And then we're going to discuss the use of antibiograms. So a nursing home specific antibiogram is actually an effective and inexpensive tool for improving appropriate antibiotic prescribing. Antibiograms should follow current best practice recommendations and guide antimicrobial selections and protocol guidelines developed in maintenance according to your programs or for your programs. And then remember that an antibiogram may not highlight emerging infection outbreaks, but it can monitor trends in antibiotic susceptibilities. Next slide, please. And so we have a quiz 3. So the most effective approach to detecting changes in antibiotic resistant patterns of microorganisms when prescribing antimicrobial therapy within a long-term care facility while guiding empirical antimicrobial therapy selection is through utilization of which of the following? That's a big question.
And it looks like we're 100% stating antibiograms.
Correct, antibiograms. Next slide, please. So with an antibiogram, providers who are prescribing antibiotics should be using an antibiogram. So when initially prescribing medication, we want to be able to identify, again, trends and what have trends related to what specific antibiotics are actually successfully when treating a microorganism. You want to make sure that you're utilizing the correct antibiotic. And so with an antibiogram, you can actually identify those trends. You can identify what antibiotics have been successful in treating microorganisms within your facility. So if your provider is prescribing antibiotics, you want to look back at like history within your facility. What have you used in the past that's worked? What hasn't worked? And you can actually use this data that generates that information for you. So you could, again, look at those trends in surveillance. So an antibiogram report, as I mentioned, also aggregates, meaning collects all your data together. So this is across all residents for a specific time period. And then an antimicrobiome reports enables prescribing clinicians to make prompt, objective-based decisions in antibiotic therapy along with surveillance, because an antibiogram provides information on local susceptibility patterns, and they may help to reduce prescribing of antibiotics with high resistant rates. So with an antibiogram, it doesn't identify specific residents. It looks at specific organisms and antibiotics that you've treated those microorganisms with. And then next slide, please. So the importance in utilizing an antibiogram is that antibiograms are only provide situational awareness of antimicrobial susceptibility profiles within your facility. So an antibiogram only includes clinical cultures. It does not provide any surveillance of rapid tests. So that's important that you understand that. So it's basically looking at microorganisms that have been identified from clinical cultures. Antimicrobiograms should not dictate which antimicrobial is used to treat an infection, but can be used to guide a prescriber in selecting the best antimicrobial treatment, especially when a CNS testing is pending. Antibiograms can also be used to track antimicrobial resistance trends within a facility over time. And then the use of an antibiogram encourages the responsible use of antibiotics within your facility, prescribing, initiating antibiotic therapy. And as I stated, antibiograms are a good way to detect changes in antibiotic resistance patterns of your microorganisms. If you do not know where or how to obtain an antibiogram, just in conversations with IPs, it's not uncommon that they either don't know where to obtain one or how to create one. You can actually obtain an antibiogram from either your primary laboratory or from your pharmacy. So we have a lot of IPs that actually obtain their antibiograms from their contracted pharmacies. And then as part of, and then you can create your own, and I'm going to talk about that in just a minute. So if you're not able to get an antibiogram from your lab or a pharmacy, you can actually create your own based on your data that you can pull from your residents' medical records. And then as part of your facilities, go back just one more, Jana. Can you go back? As part of your facility's antibiotic stewardship program in relation to your pharmacy services, I just want to talk a little bit about the importance of your pharmacy and the impact that they actually have on your antibiotic stewardship program. So with your pharmacies, they're responsible for assessing, monitoring, and communicating antibiotic use within your facility. And so this is actually in accordance to 483.45. And it does impact your FTAG of 756, and that's your drug regimen review. And so with the FTAG 756 drug review, it states that a pharmacist must perform a medication regimen review at least monthly. So you need to make sure that your pharmacists are actually providing you with that review on a monthly basis. In regards to your antibiograms that the pharmacist can provide for you, it could potentially eliminate 3 FTAGs in your building. So it can potentially eliminate FTAG 756. So those are for concerns related to the failure of the pharmacist to review and report any unnecessary antibiotic irregularity. Sorry, I can't get that out. FTAG 757 for concerns related to unnecessary antibiotic use, as well as FTAG 552 for concerns related to the right to be fully informed in advance about care and treatment. So again, just by getting an antibiogram from your pharmacy, that can actually support you and eliminate 3 FTAGs for your facility. And then you can, again, as I stated, you can also create your own antibiogram. And then that is a great resource for you just to determine, which antibiotics would guide you in treating the microorganisms in your facility. Next slide, please. And so I wanted to give you an example of an antibiogram. And so this is an example. So the slide actually depicts an antibiogram that may be created by your nursing home. I can't say that there's not like a standardized template like what an antibiotic, it all depends who's generating your antibiogram, what it would actually look like, but it should have the same information available to you. So you will see that each row represents a specific organism that's separated by the gram positives and the gram negative organisms. And then that right after the organism, there's actually a number, and that number is the number of residents who were actually diagnosed with each organism. As you see, it doesn't have a resident's name. It's actually doing a calculation, keeping track of how many residents were diagnosed with one particular organism. And then if you look at the top there, it identifies what antimicrobial was actually used to treat that organism. The second column, as I stated, is the antimicrobial that was prescribed. And then what that demonstrates to you and shows you is that what antibiotic was most susceptible for treating that desired microorganism. So with an antibiogram, you're only looking at 3 basic concepts or elements of information. You're looking at the microorganism, what antibiotic was used to treat that organism, and then you're looking at the number of residents who had that organism that was actually treated with the antibiotic and what was most susceptible for that desired microorganism. Now, the antibiogram identifies the first isolate per person, regardless of the culture source within your time frame, and then that ensures that each person contributes equally to the antibiogram. Again, it doesn't individualize each resident, it just calculates based on the organism itself. And then next slide, please. And when distributing the data, antimicroorganisms are not generalizable to different nursing homes, as they can be useful tools for guiding antibiotic therapy and monitoring antibiotic susceptibility trends within a specific nursing home. Meaning each of these, your data is individualized to your nursing home. And then once your antibiotic has been created as an IP, you're going to have to develop a plan how you're going to distribute your results to your facility. So meaning, how are you going to distribute those that data result to your physicians, other healthcare providers at your facility? And then it can be whether you want to present your information during huddle time with your staff, during routine coffee meetings. I also would encourage you to keep track, again, who is prescribing your antibiotics. Just in conversations with facilities, we find that a lot of nursing home residents who are sent to an emergency room department, majority of the time, they do come back to your facility on an antibiotic. Regardless of what you sent them out for, they come back with a prescription for an antibiotic. So you want to make sure that you're having conversations with your emergency departments. If you're identifying that as one particular provider in your facility or outside source that's commonly writing your prescriptions for antibiotics, you want to be having those conversations with them, identifying, do they have a clear understanding of the antibiotic stewardship program, your policies, and that they align with what you have standardized protocols you have put into place. And the next slide, please. And then here is an example of how this is a template, and I actually gave you a link to the template in the slides that you can actually create your own. So again, if you can't obtain a antibiogram from your pharmacy or your lab, you can create your own. And so if you click on that template, you can actually just pull that up and then you would just fill in that information. So if you wanted to create one in a short time and you can't access it or have access to one, you can create your own. So I just want to make sure you have that information.
All right,
And
great.
I think Patty will be next.
I'm next. Thanks, Tammy. Jana, you can go to the next slide. So McGear's and Loeb's criteria, I think everybody is fairly familiar with McGear's criteria, but Loeb's maybe not so much. It is a criteria that can be used for antibiotic therapy prescribing. It can help providers. Where McGear's is a look back at orders retrospectively, Loeb's is a criteria that can be used just in time. It's used at the same time that the decision is being made whether or not antibiotics should be ordered for a specific resident. So the provider would consider all the signs and symptoms that are available. There may or may not be any lab tests available, but what's the resident? What are the vital signs? What are the symptoms? If we're talking about a urinary tract infection or ruling it out, is there urgency, frequency, pain, dysuria, mental status changes? As many signs and symptoms as you can get will help the provider make the decision, and that can be looked at against the Loeb's criteria to see if it makes sense to order antibiotics for this resident. So it is a minimum set of signs and symptoms which may indicate the resident likely has an infection and that an antibiotic might be indicated. So again, it's not, there's no black and whites here, but it is a set of criteria that can help providers. And I linked the sources at the bottom there that will give you the specifics for what it would take to meet the criteria for Loeb's. A lot of facilities have started to use both Loeb's and McGear's. So we can go to the next slide.
Patty, we have a question on sort of along those lines about what are your thoughts on hospice providers getting antibiotic orders for comfort without obtaining labs?
That one's always really tricky, and I had the very same thing. It does create issues on survey. It does create issues on pharmacy review. I don't know what kind of comfort antibiotics, I guess maybe for a UTI. I think perhaps it, would be something that you'd want to look at for your contract with your hospice provider. Do they understand what your antibiotic stewardship program is about? What have they committed to following it and adhering to it? But my guess is it's probably going to have to be something that you take on a one-to-one situation. Jana, have you guys run into that before?
Yeah, I think if they're going to persist in prescribing regardless of not meeting criteria, I would document as much as you can about the conversations that were had, that the family and the resident, if applicable, were educated on the side effects, and that just document to cover your tracks.
Yeah.
Yeah.
And isolated situations aren't so bad, but if you're, discovering patterns, trends, or that it's a routine for them, then definitely something that you're going to want to discuss with the leadership.
I was going to say, elevate it up, get your medical director to call their medical director and have that conversation. Absolutely.
Yeah, generally, and I have seen it done, but it does raise red flags. So it takes a lot of documentation to get the surveyor to buy in on what you've done. So the McGear's, but it's a great question though, because that's real life. McGear's criteria is that look back. A lot of the software programs will do it for you. It determines if they feel that the antibiotic was ordered appropriately by the provider. But again, you still have to make sure that all the documentation, all the signs and symptoms are entered into whatever software or onto your line list report. Results of any appropriate diagnostic testing. As a DON/IP, I made rounds. I talked to the CNAs. That's where I got a lot of my information to put on my line list. And I was able, in that case, to get a lot of my infections to meet McGear's criteria. We'll talk a little bit more in a few minutes about what to do when it doesn't. But McGear's is not intended to assist with the clinical decisions at the time. This is a look back, and I think a lot of some facilities are trying to use McGear's instead of Loeb's criteria, but it is intended for a QAPI process to look back on your ordering practices. But again, there's a lot of literature out there that says that failure to meet the criteria does not always mean that an infection was not present, because we all know, residents that have dementia, they're not able to, tell us about all those signs and symptoms that they might have. We can go on, Jana. I think we've talked a lot about the SBAR for reporting signs and symptoms to providers. Here's a link to it. Minnesota Health Department, some facilities have built this into point-click care. They use it as part of their documentation. For new nurses, it's a great tool, even if they just practice to know what to tell a doctor, but it's also going to depend, in my opinion, on your provider. If the provider's familiar with the resident, sometimes they don't appreciate all that background information, but I do believe that the nurse needs to know it. But definitely beneficial to have all that information available when you're talking to that on-call doctor. You're talking in the middle of the night and the provider might not be half awake. But if you look down at the bottom there, it talks about recommendations and requests. So you kind of have to have in your mind what you want. If you feel that, you need some hydration, or you're just calling them and say, hey, I think we can, watch them overnight. Or, if you feel that they're unstable and that they need to go out. So you really need to kind of think through the process and know what you're asking for when you're going out. But at the same time, it's not a way to get them out of your building because you don't want to deal with them. That's not the purpose of this form. So we can go to the next one. More resources for you. I like the poster there on the minimum criteria for initiation of antibiotics. This is the third bullet point there. So we can go on. Next one. So auditing, reviewing your results. So obviously there's all kinds of things you can audit related to antibiotic use. We've talked about a lot of them already. But as you're looking to see if your residents are not meeting McGear's criteria, looking at the nurse's notes to see what kind of signs and symptoms are being documented, looking at the physician's orders to see if they are complete. Do they have the diagnosis? Is the order have an end date on it? You'll see 2567s for unnecessary medications for an antibiotic that's given for months because there was no stop date on it. Physician's progress note should address the need for the antibiotic, as well as, somebody in there should be making a note or some kind of notation about the timeout evaluation. If the antibiotic is being effective, nurses should document if there's any adverse effects. And obviously, if there's anything adverse that they, what did they do about it? What were the next steps, any side effects, as well as there need to be ongoing monitoring to make sure that the resident is not getting sicker. Are there signs and symptoms of sepsis? As well as any kind of ongoing communication with any providers need to be documented. Facilities have different ways of doing this. There's a lot of assessment tools in PCC or their software, but whatever your systems are set up in place, these are the things that should be documented. And then at the end of the month, when you're looking at which antibiotics met McGear's criteria, and if they didn't, why? Are the signs and symptoms not there? Is it a specific provider? Is it a specific nurse, a specific shift? Do that root cause analysis to see why your antibiotic orders aren't meeting the McGear's criteria, or the Lobes for that matter, but McGear's for your retrospective look back for your reporting of your QAPI. Next slide, please. Next one. So leadership roles, we've talked a lot about kind of indirectly, from the director of nursing to the administrator to the nursing home administrator. And it talks about,
Patty, I'm going to stop real quick because we're at 3:53.
okay, yep.
So I want to give the audience an opportunity to ask us questions. If you've got questions or need clarification on anything we talked about, this is probably a good place to stop and start up again next week.
Yeah. Yeah.
So I'm sorry for cutting you off.
Oh, no, I had been watching the time and then I got carried away.
Yeah. Any questions?
Just put the survey in.
Yep. So there is a survey at the bottom, and I'm going to cut to the bottom, the last slide, so that we have that. So you have the QR code so that you can continue the conversation if you need additional information. Please feel free to reach out to one of us if you need additional information about the antibiotic stewardship that was discussed today about F881, and we will pick up next week with the conversation about leadership. But Jessica, I am not able to see. I'm going to stop sharing so I can see everybody there. I don't see any questions. Wow, we don't have any questions this week. So it's an interesting topic, and it's one that I think sometimes gets buried in the conversation about infection control. I would like to share though, we had a conversation this week. Is QIA is talking about dental procedures and antibiotic use, and the focus on the dental profession providing antibiotics prophylactically. Is that something that you're seeing an issue with, or are your dental providers doing a better job of not ordering prophylactic antibiotics? You want to drop that in the chat or the Q&A, yes or no. And if you need additional resources I'm going to come up, hopefully I don't lose you all by coming back on screens. We were talking to a dark screen, but if you need additional resources on prophylactic use of antibiotics by dentists, there is an organization in Michigan. It's ran by Ferris State University that's doing a lot of research, and they've created a lot of tools and resources for healthcare providers, specifically targeted at dentists, but they're great tools that you can utilize as an IP. And I'll try to make sure that I get that link for next week for you to be able to provide to your dental providers about the prophylactic use of antibiotics and why it's not necessary with most dental procedures.
Sometimes that does have to do with like cardiologists and different, devices that have been implanted, residents will be admitted with orders, resident is to have antibiotics before any kind of dental procedures.
Yes. Is there data to support duration of antibiotics? And the answer is not necessarily. And that this month, somebody else said, I know this month I had a dentist prescribe 3 antibiotics on 3 people, pre-extraction. That is an old school of thought. And I will share that there is research out there, and I'm going to try to find, it's the MARR program in Michigan. And it is ran by, it's Michigan. Oh goodness, antibiotic. I never remember there's so many acronyms, right? But it is part of the Ferris State School of Pharmacy is where it ended up. There's a pharmacist educator at Ferris State that took it upon himself to really look at this ordering and prescribing and to work with dental organizations and dentists. And they have all sorts of really good tools. And the Michigan Pharmacy Association has it. They have joint commission standards. So yeah, I will make sure that I get you the resources out there for that. So I think it's just something good to talk about because it's one area we don't think about, unnecessary antibiotics, but with dental providers, it's something that they're starting to really hone in on and look at. Any other questions?
I think just to piggyback off you, Janet, too, a lot of wound care protocols for like skin tears or abrasions, people might decide to put antibiotic ointment on right away before there's any signs of infection. And that's also another place in your antibiotic stewardship program that you can look to reduce unnecessary antibiotics is consider an occlusive dressing like a foam dressing with borders that's not going to rip skin, but still keep that wound bed moist.
It's the Michigan MARR.org. And I believe they just became part of this Ferris State program. So I'm going to try to get their website to work. But yeah, I think we're seeing more and more, there's more and more focus outside of just very specific, UTI use of antibiotic. It's getting to be more and more nuanced and the look at in the different areas where this could be potentially an issue. And Jessica thinks she resolved the issue with chat. So yay, Jess, see, it's good to have you back at the tech. So what about nystatin use? That is huge. They're always wanting this. Trying to get the staff to use non-pharm is difficult. Yes, another good conversation. Nystatin is probably still pretty overused. Any of my nurses on here want to chat about that? No
Yeah, that
comments.
one's a toughie.
Yeah. Yeah. All right. Well, thank you all. We will pick up again next week. I appreciate you all being on today. We will have that resource for the MAR Coalition, and we'll start back up on these little bit of slides that we have left from today. Thank you for joining us. Take care.